Good afternoon, everyone. Thank you for hopping on to our December QTECH committee meeting. It is the last one for the year before we enter 2021. We're going to give it a few short minutes. I do want to give an opportunity for other folks to hop on. So thank you for being on. We do have a fun polling activity, so do take out your cell phones. The instructions will show on the screen shortly. Just give us a few more minutes. All right, so as we approach 2021, what is your New Year's resolution? If you want to participate in our fun poll today, take out your cell phone, text COVID-19 heroes to 22333. That's 22333, COVID-19 heroes, and you can answer what is your New Year's resolution? So it looks like we've got some responses coming in, more focus, exercise, weight loss, commitments, me time, reading, commitment to change, fun, self-care. Self-care is a big one. All right, if you could just give us a few more minutes and we'll be starting shortly. All right, well, thank you all for hopping on. It is about 3:03, so we're going to begin our call for today. This is our December 3rd QTech meeting. My name is Stephanie Martinez. I am the Director of Quality Initiatives here at HCN. We are very happy to have you here with us. We do have a live word cloud. It's fun. It's for the new year. It's to get our minds looking into the future. So if you have a chance, take out your cell phone and enter to 22333. Type in COVID-19 heroes. The number to dial is 22333. Dial in COVID-19 heroes, and then you can respond to our poll question, which is as we approach 2021, what is your New Year's resolution? We have quite a few responses coming in. It looks like we've got some me time, commitment to change, fun, commitments, more focus, better work life, sleep. Give you a few seconds to respond there. All right, well, let's move on. So welcome back to everyone. This is our last meeting for 2020. We will be regrouping in 2021. I want to briefly go over our agenda. We've already welcomed everyone. We do have a fun health center spotlight with Miami Beach. Dr. Torres will be presenting. So that we have up front. He'll be talking to you about diabetes. So we've got lots going on there, and we'll actually open up for questions and answers. So we hope to get you all very engaged in that. Then we're going to hear from Harut for preparing for the UDS CQM improvement measures for 2021. We do have Michael from our CISO team, our Chief Information Security Office, presenting on the National Cybersecurity Awareness Month. We do have a diabetes focus coming up also with Diana Chavez, our diabetes program coordinator. And then we'll give some brief updates and then we'll wrap up. We won't keep you on for too long. We may end a little bit prior to the hour and a half. Now, without further ado, I'm going to pass it over to Miami Beach. They are our spotlight for today. Dr. Torres, are you with us?
Yes, hi, can you hear me?
I can hear you perfect. Take it away.
Great, you have the slides, right?
Yeah, I got them.
Perfect. So I was asked today to discuss our diabetes program at Miami Beach Community Health Center. As usual, are focusing this year on diabetes, and I've spoken many times at different HCN webinars and forums on diabetes. I'm really going to focus today on some of the changes that we did to adapt to this unusual year that we've all had with the pandemic hitting us in March. I understand that in the audience, we also have Crystal Lopez, who is our Director of Quality Management, and Dr. Deepti Davas, who is our one of the directors of our population health team, and I'll be involving them as well. I don't know if it's possible to allow them to have question and answers involved to help with the question and answers, but they're there and we're in communication with each other outside anyway. Okay,
Yes,
next slide.
I've moved them over, by the way. I'm moving them over to our panelists and Dr. Torres. I
Oh, there you
apologize for
go. It's okay, awesome. There you go.
that.
Technology. You can go to the next slide. So this is how we did in the beginning of the year, and this is very typical. This is we always create these graphs. We believe in tracking our own progress. This data comes directly out of PA dashboard. It does not require any special skills. It's a very basic Excel set of graphs. There's a chart in Excel. As you can see, our performance in 2017, 18, 19 all improved, and before the pandemic hit, we had actually set a goal for ourselves to do a 10% improvement as is our paradigm at HCN from the 14.67 where we ended up at the end of the year last year. And as you can see, this is probably the same story that most of you have experienced. We started off very well, and you'll note that each year starts off lower, and I think that's a carryover from the hard work that you might have done and that we did the year before. And we were heading in a trajectory that would have put us probably close to that 12 point something goal, which is a 10% improvement until March. And then the pandemic was declared and everything started going to the junkyard. You see that instead of going down, the trajectory went up. We were, as most of you were, we were really preoccupied with just keeping our center open and making sure everyone stayed safe in April, May, and June. That's not an excuse, that's just reality. So we did not really start focusing back on our quality measures, including diabetes, until the middle of the year. Then, we started to see when we hit this, in this case, because it's a reverse measure, instead of rock bottom, rock top, I guess, of 22.58, which is high, almost as high as where we started the year last year. So we really started to refocus. You can go to the next slide. As always and this is very, very appropriate here in this forum of QTECH. We go through those quality improvement steps that everyone here is very, very used to. Try to identify what's going on, what are some challenges, come up with some ideas how to overcome some of those challenges, and then feedback, and do an assessment and feedback. So that's basically what the next 3 or 4 slides are going to be. And this first slide, we looked at our data, we looked at our patients, patient population, and as I've said many times, one of the biggest things that we do at Miami Beach Community Health Center for success in diabetes and everything else is maintain a patient registry. So we looked at our diabetes patient registry around June and July, or maybe a little bit earlier, and we saw that our A1C not done rate was extremely high for us. Normally, around June or July, we're in the close to like 3-4%. With less than 100, less than 100 A1C is not done at that time of the year. I think we finished the year last year with less than 1% of our patients not having an A1C done. That was not the case. It was more, I think it was in June, it was closer to like 10%. So that bothered us, and we tried to find a way to come up with ways to overcome that. We obviously, again, just like everybody else, there's a lower visit rate. We took a large hit. We were seeing maybe 20% of our usual patient volume in the months of March and April. And then starting in May, June, we started to creep back up. But still, the in-person visit rates were quite low. We were doing about 40 to 50% of our business as telehealth. And at that time, the providers weren't yet accustomed to doing diabetes visits as telehealth. It was mostly things that just came up, or someone who didn't want to come into the center. And we're still kind of getting our legs steady as far as what telehealth was meant to be used for and what we could do with telehealth in those months. In fact, the entire center did not go towards telehealth until May. So in that first month or two, we were trying to figure out how to make that work. Provider engagement was huge, a huge challenge. Again, everyone was more focused on getting used to telehealth, getting used to a different schedule, how to use your staff to help you with virtual visits in those first few weeks, maybe 6 weeks after we implemented our telehealth program in the middle to beginning of May of 2020. And then patient engagement, of course, a lot of, like I mentioned in the second point here, we had a lower visit rate. It's hard to get patients engaged in their diabetes care. Some of them were barely even picking up their medications, even though we set up delivery for our patients even as early as April. So it was hard to get patients engaged in care when they weren't coming into the center or even seeing their providers via telehealth. And then finally, I will say this: if you were at our, I think it was clinical quality meeting the other day, I brought this up. Leadership is important to any quality improvement project that you're trying to do, and it really has to be clinical leadership. I think that all the quality people in your quality improvement departments, people even in our population health department, if you have something similar to that in your clinics, nurses, non-provider people, they obviously play very, very important roles. But when you're trying to move providers for better or worse, when you're trying to move providers in one direction, you really need clinical leadership from among the providers. We have had an issue before, which led to our initial performance improvement in 2018, and we had similar problems this year. The plan in 2020 was to change leadership so that we could allow other people to take that role. Basically, before 2020, the leadership was myself, and I needed to take on the other roles that I need to take on and let diabetes go. So in the beginning of the year of 2020, after our performance in 2019, I felt it was time to pass it on to someone else. That didn't work. So that main point there is the importance of leadership and what to do about it when you don't find the right leader. Okay, you can go to the next slide. So here were the interventions that we took place. These are the big ones. I think there's probably other ones that are smaller, but I thought in a limited time space, it's important to just point out the major things that we did. So we initiated a Drive Up A1C program, so patients don't have to actually even enter the building. They would call us. I think we have, and Crystal can verify if she wants to, we have a room. If you use Intergy, you can set up a room instead of a scheduled appointments for one provider. We set that up for Drive Up A1Cs. Patients were encouraged to use that either through the provider staff or through the population health team, and they would just come in, get it done, and go away. We would meet them in their car. They wouldn't even come into the center and do their A1C right then and there. We used a disposable kit that, again, if Crystal wants to chime in, if there are questions about that kit later, she can answer more details about that particular tool that we used. And we saw a lot of patients coming in who had not had their A1Cs done in months, and ended up having A1Cs less than 9. So that was a big part of our program. I want to thank Crystal because she took that she took the reins of that and really made that happen for us. And then I mentioned this already, I kind of hinted at this. So for the decrease in patient visits, really encourage telehealth. And that seems obvious. And I think in a group like this, when we think big picture, we look at the 10,000 feet view. It's easy for us to say that's an easy thing to think about. But we actually had, in the time that we took to convince providers that they can use telehealth, including telephonic visits, not just video visits, to touch base with their patients, to adjust their medications, to see if there are any problems with the medications, to use telehealth as a tool to increase patient compliance with their visits, and be able to adjust their medication without them actually having to come in. One of the things that we have, and I've discussed this many times, with diabetes and other things like hypertension, we try to encourage our providers to treat it like an infectious disease. And what I mean by that is, the paradigm that we all learn in medical school or PA school or APRN school or even nursing school is check the A1C every 3 months, adjust medication 3 months, follow up your patients every 3 months. At Miami Beach Community Health Center, we have turned that over on its head. For diabetes, certainly, and also for hypertension, we say see the patient as often as you need to, even as often as every other week, so that you can get them adjusted, you can adjust their medications and get their sugars under control very quickly, instead of waiting an entire year or 2 years or 3 years to get it under control. I presented before in the past on our diabetes medication algorithm. I think that's been recorded in a lot of the QTECH meetings and the HCQIs. I think I was looking through my old presentations last night, and in fact I did a very short QTECH presentation in January this year that I think I brought up the protocol then, or medication protocol, and that protocol is predicated on frequent medication adjustments based on self-monitoring glucose readings that the patient reports to you, and visits every 2 weeks. So that's nice in theory, but in reality, it's difficult to get the patient to come in, especially our patients, to actually come into the center and get that done. It was even difficult for me, even though I really ascribed to it in the past. So much easier on telehealth, because I said this also before, take advantage of the time that you have right now, where you can actually get paid for a telephonic visit by insurance coverage, by Medicare and Medicaid. So you don't even have to see the patient in Zoom. If they can't do Zoom, if they can't do Doxy.me, give them a phone call, talk to them about their sugars. There's no reason why you need to examine that patient to adjust their diabetes medication. And that's something we pushed to the providers. It took 2 or 3 bi-monthly provider meetings to get that in their heads, and it's still something that we're struggling with, but I think that was a big part of our success in really pushing telehealth as a means for adjusting medications, and that's probably going to continue even after the pandemic. So provider scores and lists, that is also something else that we have, that I've discussed it before. We are very, very public. This topic came up again at the quality meeting that we had just 2 days ago. We are very public with our provider scores and lists. So we do this for all the quality measures, but in particular for diabetes, I sent out every 2 weeks a list of patients who were non-compliant assigned to each provider based on whether the provider saw that patient or not, and then each provider's score, and I'll show you a picture, a snapshot of that later on in a different slide. But we feel that that helps the providers motivate, and it seemed to motivate. We let that go a little bit in the beginning of this year. I probably am not going to let that go at all next year, so we're going to start that in January moving forward. And that's an important part of our intervention. That's also, I didn't put on here, but I think in my head I had to remember, I set a reminder for myself to remember that under provider engagement, some of the providers, especially our newer ones, had difficulty even with the lists and scores that we were putting out. And you could see it in their individual scores. We had one-to-one meetings. There's nothing like a one-to-one meeting with a provider who was struggling to be able to help them motivate and engage with a diabetic patient or anything actually. So the next little bullet here is using the population health team. They were absolutely instrumental in getting our diabetes score improved, and you'll see that at the end of this presentation. That is a team that we have called many things in the past. If you've heard me talk about it, we've called them our managed care team, we've called them our clinical quality care team, and now they are called population health. They were involved in multiple projects, which I'll describe in detail. That's one I'll talk more about in the next couple slides, but they were absolutely instrumental in calling patients, getting them engaged, frequent contact with patients, sometimes 2 or 3 times a week, depending on how poorly controlled their diabetes was. Again, this is a non-clinical person. This is someone who we train ourselves, and some of them have absolutely no medical experience until they come to work for us. But they are led by 2 MDs, Dr. Davas, who's with us today, Deepti Davas, and her husband, Vivek Davas. You've heard about them before, and you've probably heard them speak multiple times. And then we tried some new strategies to cultivate new clinical leaders, including inviting more clinicians into our diabetes meetings, and some other things that I'll discuss in the next couple of slides as well. So you can go to the next one. This is our scorecard for diabetes. It's very, very abridged. As you can see, it's only every month here, so I removed it just so I can fit it on one page. But you can see the basic gist, and it only starts in July. This actually, the score goes all the way back to, I think I started redoing this in like April and May. But you can see how each provider is listed. We do split it up between endocrinology and the general adult medicine providers. They're given a score based on the patients they have seen and the percentage of those patients they have seen who are diabetic, who have A1Cs greater than 9. And as you can see, they can see their monthly, actually in reality bi-weekly progress across their names. There's a trend line on the end that's more for us. So there's 2 portions of this that I want you to look at, and that's the fact that each provider knows how they're doing and how everyone else is doing in their department relative to your goals, and they can track that over time. And then the second thing is that's for them, for the providers themselves. You know, the last line, every time we send these out, the last line is the most recent one, and these are ordered in order of the highest score to the lowest score in each department, so the providers know where they stand at any given time. And then the trend line looks fancy. It's not really there for the providers. This is the second portion of using these scores. That's for us. So the team lead, so that would be myself and the clinical quality team, population health, and then other providers who are leaders. We look at that trend line to be able to determine who needs help at a specific time. So it's not just the rank any particular time, which is the green column, but it's also the trend line. And those providers who are going up we schedule an appointment with them and have discussions with them. Sometimes we go through patient by patient with different strategies to help them improve their scores. And as you can see, most people, again, this only starts in July, but even in July till the end of November, most of the providers have great improvement in their scores. I will mention this is ties into the leadership aspect. So I have farmed this group. For example, if you look at APRN Dobridnik, you looked at Dr. Johan, the other Johan in our clinic, Dr. Johan Stein, they have made marked improvements despite being very new providers. Both of them have been here just a little over a year. And because their improvement was so great in that time period, we have involved them in our leadership moving forward. And so this is another way to use this tool. You can go to the next slide. So this is our population health team, and we use them in multiple ways, but I'm going to highlight two ways in particular that we use them. So starting in around, everyone should be familiar by now, 8 months in the pandemic, you know what this picture on the right-hand side is. This is, we always meet by Zoom now, no matter what, even if some of them are in the center. It's a lot easier, so you can do these very, you don't have to wait for people to show up or drive to where you're going. So we instituted this meeting called Diabetes Rounds. And that is essentially, and that's what it sounds like. You have a list of patients that you go through that is brought to us by actually the population health team. They know they are assigned the whole thing with Diabetes Rounds starts as an assignment to each one of these staff. They get a list of maybe 30, 40 patients that they follow over time. And that list is generated from patients who, at the time we started this, had A1Cs between 9.5 and I think it was 11.5. It turned out to be about 160 patients. And they were assigned, each of them was assigned this cohort of patients that they followed. They were assigned to call the patients as little as once a week, but as often as every day. And from that list and from the initial set of phone calls, they reported to us in our diabetes rounds patients that they were having difficulty with. So either the patients weren't coming in, or they weren't answering the phone, or their A1Cs were not, their self-monitoring glucoses weren't going down. And as part of diabetes rounds, this is an incomplete group. We also have one of our endocrinologists in here. We have myself and at least one other primary care provider in these diabetes rounds. We spend about 30 minutes to an hour every Wednesday at 9 or 9:30, and we run through that list of patients and come up with ideas to improve their care and help them come in, get their A1Cs done, improve their blood sugars, and modify their medications, etc. So everyone comes together. They each leave diabetes rounds with a set of action items that they need to do before the next set of rounds. And that can be like, if it's, for example, Dr. Martinez is our endocrinologist who comes, it could be him talking to his staff to get that patient into the endocrinology department quickly and easily. Or it could be a primary care provider that I would have to call and tell them, okay, call the patient because they're not responding to the population health team or the medical home coordinators, et cetera. So things like that are action items, distinct action items for each patient that we discussed that need to be done before the next. I will tell you that we have had at least a half a dozen impossible cases presented to us, either from the population health team or the primary care providers who present their patients, patients who we couldn't get in touch with. I think there's a one patient who is completely blind and the family wasn't responding, and we have turned those patients around into success stories. I think there was one that was in a nursing facility, and we couldn't get in touch with the guy. We were having trouble getting him in. He had a whole bunch of other health needs, transportation issues. That was presented to us, so literally presented to us as, I don't know what to do with this. This is an impossible case. I'm not having any success, to getting his A1C down to, I think it was like 7.8. Maybe Deepti can correct me later. It was from like 11 to 7.8. So there's a lot of success stories just from this weekly meeting that we have with the population health team and a couple of providers, as well as the clinical quality department. You can go to the next slide. And I can answer questions about that at the end if you have more questions, but that was one of the biggest things of our success. This is how we measured success. So we assigned to the group of people, 160 patients. I think it was in the middle of August. We decided 160 because it happens to be 4%, and we were around 20. So if we got all 160 compliant, which we knew wasn't going to happen, but still, if we got a large number of them, this is the kind of calculations we do in our heads here at Miami Beach. We were at around 20 in August, and if we got 160 patients under control, that would bring us down to 16. So that's part of the reason why we chose 160. That's how we set the parameters of A1C 9.5 to 11.5, because it turned out to be about 160 patients with that number. So the left-hand side, as you can see, the assignments. The green represents patients whose A1Cs that were initially uncontrolled are now under control. Yellow means that they had not had their A1C checked in over 6 weeks. So it's time for sure. They're way, by our standards, they're way overdue for getting A1C done. And then red are those who had worsening A1Cs. And they just get this, I send this list out every time we have a meeting, and they go over that to know what their progress is like. The overall view, the higher level view, is on the right. So this is the progress, and what you're seeing is, again, each reporting period you have, or each reporting date, you have 161 patients. The dark blue are those that are compliant, who have been brought into compliance, and then the light blue are those who are not in compliance. And you can see that they went from 2% the first, after 1 week that they brought into compliance, to over 55% more recently. That's a market improvement. That 55% or almost 90 patients that they got under control represents 2% of our improvement in diabetes. In other words, 2% more of our patients became compliant because of this project and this tracking project. You can go to the next slide. I think I'm way over 15 minutes here, but this is the fruits of our labors. I will tell you, as Dr. Rabinowitz likes to say, and I will, our CEO, I would like to echo this because it really is true. It's just hard work. You have to come up with strategies, and you have to put in what I've been trying to get across to everyone is it's a lot of work. Weekly meetings with a lot of work in between of those weekly meetings, in addition to our bi-weekly integrated diabetes meeting that we have in the afternoon. So the staff that you saw in that Zoom meeting attend 2 meetings every 2 weeks, and then 1 meeting in between to do work. It's clinical work. It's as if they were seeing patients themselves, or being part of that team themselves, but it does take all that work, all the tracking. This takes up a lot of my time every week to be able to do these reports and do the tracking. As you can see, it worked. We started this in earnest, coming back to diabetes and focusing on it around, you can see the July, at the end of the month of July, we're at a peak of 22%. We've had some modest improvements in that month, and then really started adding things like the population health team diabetes rounds towards the end of July, early September. And when we started that, that's when our curve started a steep descent. If you look, our most recent number, I think it was 2 days ago, was 15.82, which is below the 2020 goal. And I think if you follow that curve all the way down, if you do some mathematical manipulation, you can see we're headed towards around where we ended up last year. The calculations that I had specifically was between 14.28 to 14.56 by the end of the year, if we continue the trend over the next 3 to 4 weeks before the end of the year. So it works. That's the last slide I have. You can go to the next one, which is just thank you. Thank you for listening to me for longer than I had. I have a tendency to go over, but I was told that that's okay. So
Yes.
hopefully you guys found something useful. And Deepti, Crystal, and I are open for your questions.
So yes, thank you very much. It was very engaging. They are able to unmute themselves because I did move you over, Deepti and Crystal, to the panelist side, so you can unmute yourself. We do have some questions in the chat that I wanted to start with. So Andrea Brooks is asking us, did your population health team focus on just this group of patients, or do they work with other targeted populations or have other responsibilities? How much of their time was dedicated to this project? So a little deeper dive on that.
So I'll start really briefly by saying that, and I promise really briefly, that my understanding is they're not, and I can tell you that for sure that they're the ones that I showed you, the picture of the 3 or 4 that we have working on diabetes. I know we're also working on other projects because they come to another meeting related to HIV care. Dr. Dabas, if you unmute yourself, you can give more detail.
So we do, hi. So we do end up working on several different lists, not just this particular one that Dr. Torres produces, because we also get lists of diabetics from our insurance, the insured patients from the insurance companies. And like Dr. Torres said, there's also the retention and care where we work with the HIV patients. And if there's any diabetics in that list, then we end up working with those also. So it does end up being various different lists. So basically any patient that they come across, we check, if they're diabetic, and if they are, then we treat it all the same like we would if they were part of the integrated diabetes program, where they get their A1C, did they get their eye exam, did they go see all the different, the podiatrist, the optometrist, etc. So it does end up being different lists. How much time goes into it? Since the particular set of patients that Dr. Torres first provided us, every of the 4 people, they all got about 30 to 40 patients. And because it was more, it required daily calls, because that's how we started, that a daily call to call the patient and ask them for their fasting blood sugar. So, they would have to call each one of those 30, 40 patients every day. A lot of them was a lot of continuous outreach to try to get a hold of someone who could get us in touch with the patient. I would say it took about 2 hours of their day. And then they did other things. Now it's obviously less because now it's like streamlined. Now they know the patient. There's some patients who agreed to the program and who are expecting their call. And there's some who became compliant, so we don't have to call them anymore as often. Even though we do still call them every week just to make sure they're taking their medications and all that. We did also work with the pharmacy department a while ago to convert all the patients who were not picking up their medication and didn't know that delivery was available because they never chose that option before. We called each one of them and told them that we could deliver their medication, and that was in the beginning of the pandemic, and that did help a lot too. I think that's it, right? Was there another aspect of that question that I missed?
No, I think that covered it real good.
Okay.
And Andrea did message the chat back and says, makes sense. Thanks for sharing the additional information on the team. We do have a question in the chat from Chris in Hawaii. He's asking, when you get the A1C done more frequently than every 3 months, do you run into problems with insurance coverage and patients getting stuck with the bill?
Never. I think also Dr. Davas can answer part of this question because she's and her team are in constant contact with the patient, as she just said. I have never heard a complaint from a patient. Usually when we get complaints from a patient relating to a lab bill, that comes through our lab director and me, and I've not heard one, to my knowledge, for the past 3 years that we've been doing this.
We haven't. And in fact, when we meet with the insurance companies, they're amazed by the diabetes scores and they ask us how we're doing it. We haven't heard any complaints about it.
Ooh, sorry, I was on mute. I was there like, okay. All right, so yes, thank you for that. We also have another question in the chat. Does Miami Beach have a nutritionist on staff?
Yes, we have one, actually not nutritionist, she's a registered dietitian. I did not go into that in depth because we've talked about it before, but as part of our integrated diabetes program, which set us off on our path towards all these improvements from 2018 till now, we have a bi-monthly meeting with the dietitian, all the endocrinologists, a few primary care providers, and some other stuff, behavioral health staff. So we have a fully integrated program. We have also with telehealth tried to leverage that because in the past we had to schedule patients, we had to schedule our behavioral health providers with a dietitian, and a patient would come at a certain time of day. We started doing something called diabetes clinics, where on a half day each week, all 3 people are available in the same physical location, so the patients can go from one to the next to the next. With telehealth, it's been a lot easier because if they're being seen by telehealth, the next provider can just come in. I don't have exact numbers for you, but that has been responsible in the past, having the dietitian and behavioral health integrated into this team-based approach has been responsible for some of our improvements in our past, and I assume this year continued. And again, we meet every other week. Currently, we just had a meeting last night with all these different people, including pharmacy, which again, I didn't mention in this talk, but I have talked about before. They are very crucial to our improvements, including this year's.
Thank you. If you're willing to take more, I've got a few more.
Sure.
I've got a
As much
question
time as you
about
want.
I've got a question here. About the drive-through A1C. How often are you having them, and about how many patients do you see in your drive-through?
So I'll let Crystal answer that question. I think it's every day. We don't restrict the amount, but I'll let Crystal answer that question.
That's correct. We didn't limit it on, a day of the week or a time of day. We opened the schedule to when the patient was really available. We wanted to make it as, easy as possible on them. So we made sure that they had access to us Monday through Friday. They can come in the morning, they can come in the afternoon. We just do it based on them. And usually we get anywhere between maybe 1 and 3 to 4 patients a day. It's not a large number, but we have been able to, over the course of the last several weeks, bring in several patients that way.
Okay, and then I have another question. Does Miami Beach give any blocked admin time for quality leadership activities?
We don't yet. So if you're talking about like an entire day to do leadership, so for myself, I guess you could consider that. I'm become over the past 2 years really more administrative than clinical. So I have before the pandemic, I had 3 half days set aside to see patients, and then the rest of the time I spent on administrative. I don't know if you want to consider that a blocked admin time, but my role is different. As far as the other providers who see most patients, we do the diabetes meeting, for example. The integrated diabetes meeting happens after clinical hours on Wednesdays, and just very recently for 2 of the leaders that I'm cultivating who I've asked to come to our diabetes rounds, I've given them an hour or 2 in the morning just on Wednesdays to be able to attend diabetes rounds and discuss any other patients they might have. That just started this past Wednesday, and one of them had a tooth problem. So it really didn't come. He didn't come into the clinic anyway that morning and didn't attend. But in the future, I think we'll have that small amount of time. So it's not like a half day or anything or a couple days a week. It's really just small amounts of time.
It's great for cultivating leadership. And then one more question in the chat. What % of patients are seen with telehealth? Are all providers doing telehealth, or a subset of providers doing the telehealth?
So that's a great question, and I don't have the answer specific to diabetes, but I can give you a general answer. Our percentage has been steady since about June at about 30% a day of our total visit count being telehealth patients. We have one of our mitigation strategies for COVID has been to decrease the physical presence of providers and staff in the center. So people don't work most of the providers, adult medicine providers certainly, don't come to the office every single day, maybe 2 to 3 to 4 days a week, depending on the provider. And the other days they do telehealth. So it's a very timely question because I'm doing schedules for the first quarter of 2021, and I've been contemplating, with the vaccine and everything, et cetera, if people are coming back to work, how we're going to mitigate telehealth in the future, or how we're going to do telehealth in the future, and I don't know the answer yet. But currently, it's about 30% of the time doing telehealth. On those telehealth days, they do 100% telehealth. There are providers, for example, the endocrine team. There's only 3 of them, so they're in the clinic more often. They do telehealth on days that they are in the office as well, although it's a much smaller percentage. And at one of our centers, for whatever reason, I haven't interfered in it because it seems to work, that nurse manager decided that they will also do telehealth on the days that they come into the center, but they still have dedicated telehealth days. So we have to figure that out. That's a great question. I don't know how we're going to do this after the pandemic is over. Hopefully, this time next year, I'll have a better answer for you.
Wonderful, thank you.
And I just wanted to jump in. Thank you so much for sharing, Doctor. Torres. I do have a follow-up question for Dr. Dabas, I believe it was. You said the population health team calls patients to assess their adherence to medication. And I was wondering, how is the team documenting this and tracking this in the EMR?
So we are actually not documenting it in the EMR. We created these Excels with tabs dedicated to the patients, and we put in a little box for, patient taking medication or not, and I have the team just go in and, write a check next to it. And if we have a patient who we think is not, then we task the provider or the provider team and let them handle it. Just because, like Dr. Torres said, our staff is not, the population health team is not clinical. But we let the provider and his team know that if there's a particular patient who's not taking the medication because of, they're getting sick or because of financial reasons, whatever it is, we let the provider and the team know.
Got you, thank you. And then I had another question regarding diabetes technology. I know that Miami Beach has an endocrinologist on site. How much have you seen an increase in the use of CGM, or if you guys were using it before? How is that data interpretation being documented as well in the EMR, I'm sorry.
That's a great question. We use Greenway Intergy, and right now there's no easy way to import it into the EHR. In other words, there's no structured fields within Intergy currently that will allow you to import any glucose monitor, whether it be a CGM or the traditional type of glucose monitor. You have to kind of enter it either manually, or you have to scan it into the chart. We have increased our CGM's use because we are taking part of the Diabetes Echo project, and we got a grant, the University of Florida Diabetes Echo project, and we got a grant through them to purchase, I believe it was like 50 CGMs, and then we're applying for a different grant to be able to purchase others. And we have encouraged the use of CGMs in certain settings. We're looking at that. We actually had, for our diabetes management meeting yesterday, we had discussed the role of CGMs in some of our more difficult patients and what the criteria are, and we're currently working on making that more widely available to all our other providers, and we're looking at the data to see if it's made a difference in those patients who are using it. Dr. Davos will tell you, if she wants to come back, that some of the patients don't like it, but that was one of the topics that we had discussed yesterday. For various reasons, but if we have expanded, it's primarily been because of these grants that we have. And then as far as how they get the data into the chart, if it's one of the ones that has a website, which I think is some of the ones that the University of Florida are pushing, they take a printout of that output on the website and then put it in the chart. Or the provider does like a narrative of what the trends have been.
Excellent, thank you so much. And I do have one additional question, which I'm going to use as a plugin for my section in a few slides in the future. How has Miami Beach integrated the screening from pre-diabetes or diabetes into the workflow or the encounters? Is anybody from your team taking the time to do screening for pre-diabetes?
So that's a great question. It turns out that we actually have, we had our operation site visit last year in March, literally right before the pandemic. I think they left and the pandemic was declared like 2 days later. So, and if you've had your OSV in the past year, you know that they're focusing on diabetes, and they ask you to do 3 quality improvement projects relating to diabetes or diabetes prevention. And one that we had chosen was the documentation of prediabetes in the chart and the screening of appropriate patients. So anyone with a BMI over 26 or higher, who's over the age of 21, I think, should be screened with an A1C. It turns out that that was actually part of our workflow already. So we're doing very, very well as far as meeting the goals that we had set for ourselves through that HRSA project. And it's like, for example, for screening for diabetes with A1Cs, it's somewhere in the 80s that we're, as far as that's concerned. And then the documentation of prediabetes, we're working on improving that as well. So it already has been part of our workflow, and we are monitoring it, although not to the detail that we do with diabetes yet. that's in the works for the future.
Excellent. Thank you so much.
Well, thank you. Thank you to Miami Beach. Thank you for taking the time to present to the QTECH committee. Thank you very much. We always appreciate having you on. If there's any other questions, Dr. Torres, we'll just forward them on to you via email,
Of course,
okay?
yes, of course. Yeah, I'm always available by email or phone for those of you who have my phone number and my email address, obviously.
All right. Well, moving on, I'm going to pass it over to Michael Sangili. He is our CISO network security engineer. Michael, are you with us?
I'm here. All right, so hi everybody, welcome back. So we wanted to cover some recent, really important stats that have come up as of October. These stats came from October. They're usually a month behind, so we got them towards the end of November, and we felt this would be very important to share. So in October, over 2 million patient records were exposed. That's a very scary number, and that is across all realms of healthcare. So it's not just at the health center. This can be in any other healthcare space that you can think of. But just some key factors that came into play with these 2 million patient records that were exposed, where more than a third of them were breaches via email, which means essentially phishing emails. Either someone entered in their username and password into an email and exposed that network over to hackers, or maybe they downloaded some sort of malware file from an email and then it exposed the network again to hackers. Or it could even have been anything as like ransomware, which is also a file that gets downloaded via email. So again, it continues to be email a lot, even though in October, well, with these breaches, surprisingly, email wasn't the biggest factor, although it typically is, but it's always something to think about. 3 of these major breaches occurred due to employees mishandling PHI. And this could be anything from employees downloading PHI to other systems or to maybe a USB stick or whatever it may be that they use to download, or it could even be IT, moving over to a new system and transferring PHI, and then in the meantime they're not storing PHI in the right encrypted hard drive or encrypted space, and then attackers find out that this PHI is sitting in an unprotected area, and then they take advantage of it. So 3 major breaches occurred from that, and 40% took place over a network server. Essentially, these are the real hacks. That 40%, those are what you see like in the movies when people are typing on screens and getting into networks. That's what 40% took place over a network server means, which is actually a very high number. That's not typical at all. It's typically through email. Usually it's like 80-90% over email. But the way they get into these servers, usually it's not just that they are just so sophisticated that they can get into any server. It's really more than likely that server was an old server sitting there, hadn't been updated in ages, is running a very old version of Windows, and no one ever took the time to pay attention to it. So hackers look for that one weak point. All they need is just that one weak point. They found it, they get into your network through that one server, and then they begin their further planning on how they're going to spread around your network and find your PHI, which is the goal. They get into one point. Just because they get into one point doesn't mean they automatically win and get access to your PHI. But once they're in that one point, they start looking around and trying to find out where your PHI is and then try to exfiltrate that information. So some of the key takeaways that, and these are the things that we typically say that could have just protected you from these types of attacks, but some of the key takeaways are phishing. That's going to continue to be a major threat. That's going to almost always be around. It's not very sophisticated, and all they do is just trick people into giving up username and passwords. So ways to stop that is just continue education and training amongst your staff when it comes to security. Perform your security awareness trainings annually or monthly or quarterly, as often as possible. Because again, it's not about a sophisticated attack. It's all they really try to do nowadays is get your users to put in their username and passwords in places they shouldn't, and then they're able to gain access to your network. So continue that education, whether it be in-house or using third-party companies to provide that for you. Doesn't matter, just get it done for your users. Make sure your devices, your servers and your devices are up to date. So like I said, that 40% was more than likely just because an old server could have been resolved by probably easily just updating that server, which is not as easy as it sounds. Sometimes there's hassles when it comes to updating servers, but you got to get it done, because we hold PHI in healthcare. We have, very important information in our networks. So we have to make sure we're up to date and as secure as possible. So just make sure you update those servers and devices. And it's not just, Windows machines and the computers. Sometimes in IT, we forget that we have routers and switches and firewalls that have firmware that need to be updated, which can also be taken advantage of. So for my IT folks on this call, remember, don't forget about your routers and your switches and your firewalls. They all have their own special firmwares that need to be updated on a consistent basis. And lastly, periodically conduct a vulnerability assessment to determine if you have any major vulnerabilities in your network. I just spoke to a health center yesterday and found out they were doing vulnerability assessments themselves in-house across their network, which is phenomenal. That is great. If you can do that in-house and get the training for a staff or somebody in your IT team to consistently run a vulnerability scan across your network, do so, because then that will tell you any of those devices that you might have not updated in the past, or maybe that firmware on that router that hasn't been touched in a long time. That'll let you know that those devices are out of date and they need to be updated because of a major vulnerability that lies in that current version that it has. So just make sure either conduct it in-house, train somebody if you can. If not, you can reach out to any companies and they can provide this service for you on a monthly basis, on an annual basis. Just make sure you're up to date on any vulnerabilities you may have in your network. Next slide, please. So more cyber threats that have been coming up recently. We jumped on a call with HHS, CISA, and FBI, which they really just issued an imminent cyber threat. They were very vague as to what this cyber threat includes or who it's coming from. But we disclosed this information out to many of you at the health centers on the IT side and some of the CIOs at the health centers. But essentially, they said there's ransomware attacks that have been coming or actually have already happened. There's been several large breaches around the nation in healthcare that have received ransomware attacks, and that essentially locks up all your patient data or all your data, period, and you can no longer access it. So ransomware attacks are the primary goal of these hacking groups. Ransomware attacks are typically deployed via phishing emails. So again, they'll send you an email and they might not try to get you to put in your username and password, but it might come like an attachment, and maybe looks like an Excel doc and might ask you to do a few things or enable or download something. So that's why you always have to be wary of what you're downloading. Always make sure who the sender is. Make sure it's somebody legitimate that you know. If not, do not open any attachments, because again, this is how they deploy ransomware. And so if you download that file, what ransomware does is it uses something called a worm, which is a type of virus essentially, or a type of malware. And it's a tactic that what it does is it propagates across your whole network. So once you download it, it begins sort of scanning through your network to see all the devices it could actually sneak into. Any of these old devices that haven't been updated, those are the prime candidates for these worms to sneak into, to deploy its ransomware into all these devices. Then it encrypts all the files that are on those devices with a key that the hacker has only for himself, and he holds those files ransom until you pay them, usually via some sort of cryptocurrency. And then if you pay them, they will unlock it for you, or they may not unlock it for you. It's something you never want to trust, but that's sort of how ransomware works. They hold your files ransom and they encrypt it with a key. So ways to protect yourself from this ransomware: always use an updated anti-malware solution on all network connected devices. And we put updated in capital letters because we've seen plenty of antivirus and anti-malware software out there, but it wasn't really maintained and it was out of date. And when it gets updated, what anti-malware systems do is they learn these new viruses that were created. So if you're not updating it, any new viruses that come out, you may not be able to spot it, or your malware solution may not be able to spot it, and then it will still infect your network. So make sure you have some sort of anti-malware out there that's always up to date. Again, you're going to see a lot of these same bullet points, because a lot of these same tactics can stop all sorts of attacks out there. So make sure you keep educating and training your staff on security training to show them how to spot those phishing emails so that they know not to download files if they don't know where they're coming from. Make sure you keep all your devices and servers up to date, because if they are up to date and ransomware gets into your network, it may not be able to propagate across your network because it doesn't have the capability to get into the latest version of your software. So make sure all your devices are up to date. And again, periodically conduct vulnerability assessments across your networks to make sure that there's no major vulnerabilities out there that that malware or that ransomware can take advantage of. And these tips go also to your home. This is not just a network, an organization thing, a company thing. This is the same tactics they use in people's houses. And some of those are usually less sophisticated, but what they do when they try to attack you at home is they send out a mass email to huge email list they download. They're able to find email list of hundreds of millions of emails out there, and they'll send out these spam emails to all these emails in hopes that they get a few bites, which they always do. Someone will always click that email, someone will always download that attachment, and now your computer at home that has all your family pictures for years and years and years becomes encrypted by ransomware, and then they will hold you ransom in hopes that you pay their ransom to get your files and your pictures back. So remember, this isn't just here, this is at home. Always make sure you check out those emails that they're sending to. Make sure your computers at home are also up to date. I know a lot of times at home we see that Windows would like to update your system or Mac would like to update your system, and we keep skipping and skipping and skipping, but make sure you always update those devices to keep yourself safe from attackers at home and in the workplace. And I believe that, next slide. And the last thing we wanted to mention, I know we're short on time, the cybersecurity educational and collaborative learning webinar series that we've been conducting. We're now on session 5. We are almost done. We have one more session. This is actually, session 5 is really the last technical session. The last session 6 is the one where it's sort of a wrap-up call. Everybody gets back together. We'll have our CEO, Alex Romeo, a couple of the other CIOs from all your organizations, and we'll discuss of all the findings and tasks that we've completed. So this next session coming up is going to be completing sections 4, 5, and 6, which is going to cover physical security procedures, things like your badge system, things like your server room, how is it protected, cameras in your organization to make sure everything is being viewed and being monitored. And then we'll also talk about business associates agreements and vendor access to PHI. So business associates agreements are your BAAs, which is basically the language you give to any third-party vendor or contractor that may be needing access to your network, and basically lays out that they need to handle PHI professionally and correctly without exposing any dangers in your network. And then the last bullet point there is backups and data recovery plans, which is a huge topic on session 5, which we'll be covering will be the majority of the time. So making sure you have all your backups in your organization and data recovery plans in case any kind of disasters happen in your organization and you need to restore from backups. So we look forward to seeing everybody in session 5 and wrapping up that last technical session, and then we're almost done. And from there, you should all have your own completed security risk assessments. So thank you, everybody. I know we're short on time, so I wanted to do it a little fast, but thank you, everybody, for your time, and we look forward to seeing you guys again.
Thank you, Michael. And for those of you who have missed it or think that someone at your health center could benefit from the cybersecurity webinar series, we do have them recorded and we send them out to all registrants every month as they've been occurring, but we'll send them out after this meeting in our follow-up email that we always send out, our communication after every committee meeting. We'll send it to you there so that you can forward it on to the appropriate folks if you think it's worth sharing. Thank you, Michael.
Thank you.
All right, I'm going to hand it over to Harut now. Harut's going to talk to us about CQM improvement for 2021. Harut, are you with us?
Yes, I am. Thank you. Can you hear me?
Yes, sorry, I was muted. Yes, we can
Okay,
hear
yeah,
you.
you had me scared for a minute. All right. So just what a fantastic presentation from Dr. Torres, and a lot of what I'm going to talk about kind of, I get nuggets of wisdom from all of the centers that are doing well in certain things, and of course, Miami Beach is doing fantastic with diabetes as well as other measures. So, and I'm glad that he went first, as he has you thinking as far as like, I know your brains are ticking. What can we do at our center? What nuggets can we take and apply in our center? And that's what we really need to do. 2020 has been tough on our UDS quality improvement measures. COVID has taken a toll on our compliance. just nationwide, I think it's an issue. But here's our opportunity to start thinking about, okay, how do we prepare for next year and just kind of wrap up this year. So I'm just going to present you some general thoughts on, some of the things that we should be doing. Some of you probably already doing these things, but general thoughts on how we should right now start preparing for 2021. A lot of us have now gotten accustomed to telehealth. We'll probably be doing that for a while longer. And so we can organize ourselves to try and improve our quality measures for 2021. So the first thing is really to review where you are right now, and just pick which ones you want to concentrate on next year. We want to do well on everything, but as far as like putting together a QI plan, you're probably not going to be able to attack everything. So it's best to pick the ones that you really want to concentrate on. Make sure that you review the measure specifications with your staff. Sometimes we see that there's not quite a clear understanding on what qualifies the patient for both the denominator and the numerator. What are exclusion factors? It's always a good time now to make sure that everybody is clear on this. And then train or retrain your staff on optimal workflows for these measures, and develop your improvement strategy. Try and include your staff in this process. When you get buy-in from staff, I think it makes it work much better as far as like implementing and getting results. Plan for regular data collection. As Dr. Torres said, we have to see where we're going to see if we need to tweak our strategy, if we're not seeing the desired changes, if we need one-on-one conversations. So this is the time to kind of put together your plan for what you're going to implement, what you're going to really concentrate on, how you're going to measure the data, how often, and how you're going to share that data with your staff. So this is just in general. Now, going into some of the specific measures, just a few thoughts on some of them, which I know most of you are planning on. So if you go to the next slide, in conversations that we've had one-on-one with you guys, or even in some of the meetings that I've attended where you're present and we've asked the question, what are you going to concentrate on in 2021? Across the board, everybody said diabetes. So, and as a network, this is one of our priority areas. So one of the first things, we all seen in the past few years where we've actually been delving into the data a little bit more is, HbA1c not done is quite a significant number for a lot of us. And Dr. Torres talked about that. I mean, that's one of the first things they set. They set that goal for having a very, very low HbA1c not done rate at their center. And that helps, because if you don't know what their HbA1c level is, you don't know whether they're controlled or not. And so that's one of the things that we really need to try and work on, try to really reduce that not done rate. And so one of the things that I always talk about is, at the beginning of the year, consider doing that HbA1c test on all diabetic patients during their first visit for the calendar year, regardless of the due date. And I know sometimes that's an issue with insurance. Some insurances won't pay unless that HbA1c is done in an interval of greater than 90 days. But is this something that you could consider maybe doing and eating that bill? Again, I can't answer that question for you, but if that patient comes in, say in February, the last one was done in December, they're not yet technically due, but then they don't come back for the rest of the year, that patient is in your denominator and they're going to fall in your non-compliant because you don't have an HbA1c. So at least that first visit, if we can make sure that we look at that record when we are dealing with that patient, and if it's their first visit for the calendar year, then just go ahead and do that HbA1c test if possible. Most of you have point of care machines. That's one of my other points. Point of care machine at this point is really a must-have. You need to be able to do those HbA1cs when you see the patient in-house, not have to rely on them going to the lab. Another one where sometimes we see an HbA1c might be missed is, if you're diagnosing a patient for the first time and you're putting that in their problem list, again, especially those of you who have, urgent care centers or such where you're seeing these patients and you're going to add that to the problem list. If you're going to add it to the problem list, just bring that point of care machine over, do the HbA1c, get the result in. Again, if that patient never comes back and you don't have an HbA1c on them, they're going to fall in that category of not done. So little things like that that can help you to at least make sure that we get that portion of the non-compliance, taken care of. Then, of course, we have caring for the patients with poor HbA1c. And that's where a lot of what Dr. Torres spoke about comes into play. Integrating behavioral health and nutrition education into diabetes healthcare as much as you can. And I know not everybody has in-house dietitian or a nutritionist, but if we can see if we can find any kind of referral program that we can use, that is a critical part of really taking care of our uncontrolled diabetics. More frequent follow-up appointments, as Dr. Torres also just mentioned, they've found that to be very, very effective. More frequent touch points with your poorly controlled diabetics. And helping patients set self-management goals and following up with and encouraging patient adherence, both with their medication regimen and with their self-management goals, walking, exercise, things like that. So all of these are things that we should think about as we put together our strategy for improving our diabetic. And again, everything else that Dr. Torres said, I can't, they're doing fantastic, and we need to learn from those that are doing well. All right, next slide. The next measure that we hear a lot of people talking about that they are going to be concentrating on is blood pressure control. Again, uncontrolled blood pressure, patients with uncontrolled blood pressure, again, would benefit from more frequent touch points, as we said, the same with diabetes. As far as our support staff, we just need to make sure that they're doing the blood pressure, doing the blood pressures correctly. We have a training video that is available. This is hyperlinked. You can see that. Make sure that they're doing a second blood pressure reading. If the first one is high, allow the patients to sit and rest a little bit. All of these things can make a difference. Make sure your providers are aware of the HCN hypertension treatment algorithm. Again, we do have a training video and the link is here, but that has also, those centers that said that they've adopted the treatment algorithm, we find that they have made improvements in their blood pressure control. And again, helping patients with self-management goal. And with your telehealth visits, I know we took a hit. In the earlier part of this year, we were not allowed to capture self-reported blood pressure measurements. However, more recently, I think in the last, I think sometime in October, UDS did come out with an amendment, so to speak, to that, where if the patient has an appropriate blood pressure machine and the provider or support staff can visually see the blood pressure reading with a date and timestamp, that could be counted towards UDS, and that measurement would have to be entered into the EHR in order for it to be counted. So let's make sure if we're doing a telehealth visit with a patient who has a blood pressure machine that's appropriate, that we can ask them to show us their blood pressure, or actually even have them do it in front of you. That way you can also coach on proper techniques, and we can use that. And of course, I did include the link here for frequently asked questions sheet that we prepared that goes into detail on what is allowable with self-measured blood pressures as far as UDS. All right, next slide, please. Just some thoughts on a couple of the other measures. So these four measures, pediatric weight assessment and counseling, adult BMI assessment and follow-up, tobacco screening, and the depression screening. These four are, quality measures that are really dependent on workflow. These are things that you do when the patient is in front of you. There's no additional cost. There's no lab to send out. These are things that you can do at the visit. With tobacco screening and depression screening, these can be done also in telehealth visits. So there's really no impediment to doing them. And again, this is one of the centers that do the highest, or that have the highest compliance, are the ones who have adopted a strategy of just kind of doing this at every visit. And if doing it at every visit is too much of a burden, at a minimum require doing it during the first visit for the calendar year, regardless of due date. Again, you want to avoid having patients who come in once, you miss doing any of these assessments, and then they don't come back again, and they are in your denominator already, and they'll be showing up as non-compliant. With pediatric weight assessment, they do have to have at least one visit with you physically. They have to have an on-site visit because we cannot count self-reported weight and height for the pediatric measure. So unfortunately, that is one that if they are seen in a telehealth visit, they'll still fall in your denominator. So again, trying to make sure that there's a comfortable setting for pediatric patients to come in, whether it's separated area or separated time when it's only pediatric patients, allowing them to sit in the car until they have to come in for their visit, things like that can help. For the adult BMI assessment, the measure steward did make an adjustment to that measurement. And so if the patient is only seen in a telehealth visit during the entire calendar year, then that patient will not fall into the denominator. So at least that's one that we don't have to worry about. But if they do come in physically, make sure you get a height and a weight. That's the only way that the BMI can be calculated. So you have to have at least one visit in the year. You have to have a height and weight done on the same day. And if the BMI is out of range, of course, you have to do the follow-up. Okay, next slide, please. Actually, I didn't talk about training. So yes, you do have to make sure that you train your staff on these processes. One of the things that we found with support staff is if you train on these processes, if you put in your expectations, whether it's at every visit, do have periodic observation by supervisors, periodic chart reviews. And again, in the centers that have done the best, they've actually incorporated the results of these chart reviews. And it can just be a random 2 or 3 charts a week that are reviewed for having done these steps properly. And if you incorporate that into your annual evaluation, then that gives even a little bit more motivation to make sure that these things are done according to the guidelines that you set. For pediatric compliance, again, this is a good time to look at this. This is flu vaccine season. Flu vaccines are very much one of the vaccines that trip us up with compliance for pediatric immunization. And I always encourage it at this point. We should be running our reports for our patients turning 1 this year. This is the time to really run that report and make sure we get them in for the flu vaccine this flu season. If we wait till next flu season, they may turn 2 already. And then even if you give it to them in 2021, they may not be compliant if they turn 2, let's say in June, right? So you want to catch them now. You want to catch them for this flu season. And while you're at it, make sure you check their other vaccines, especially rotavirus and PCV, which have very strict timelines on when they have to be done in order to count for compliance. And as always, make time to check your state registry for any vaccines that you can add to the patient's chart that you may not already have. Okay. With cervical cancer, this is one of the ones that took a hit again because COVID. We've had some patients that had not been willing to come into the center. I think more and more patients are starting to come in now. So again, let's make sure that we are encouraging pap smears to be done anytime we see that a patient is due. Encourage all providers to perform pap screenings. Not having to make a patient come back in for a separate pap visit helps. Now, I know patients are not always willing to do it on just the spot, but there are some who will. So let's make sure that we check, and if they're due, try and make sure that they get it done that same day. Colorectal cancer screening, same thing. Some centers are actually offering the FIT card and asking them if they can provide a sample that same day. And some will say yes, and some will say no. Again, follow-up is very important with colorectal cancer screening. If you're giving them the card, we do need to follow up to make sure that they get it back. Those centers that are very dogged about following up with their patients get the best results. And again, little hints that we've learned from many centers, patient incentives work. So again, if you can get a little local grant that can help you with this, that would be fantastic. Also, the more people we can get to have the colonoscopy rather than the FIT, once you have a colonoscopy, they're good for 10 years. So try and find, local referral providers, maybe some that might be willing to give discounts for uninsured patients to increase your colonoscopy screenings. Next slide. Okay. So I think it's moving slow, but talking about those measures that involve medication therapy. That's the next thing that I wanted to talk about. I don't see the slide moving, so.
Harut, you don't see the slide?
I'm still seeing pediatric immunization.
Oh.
But I can keep talking because I have it on the side.
Okay, because I did move slides.
Okay, so for the measures that involve medication therapy, and in this case, we're talking about IVD and statin therapy. Basically, usually it's a smaller denominator. We do want to try and identify the non-compliant patients and have their PCPs review the record to ensure the accuracy of the diagnosis. Sometimes we find that patients may have been inadvertently misdiagnosed. So we need to make sure that we are identifying those. Another thing that I want to, especially with the statin therapy, please review the measure specification with your providers. We have been hearing that some of the specifications that pertain to the UDS clinical measure, some of them may be newer as far as like what the levels of LDL for diabetic patients are that need to have statin therapy. So make sure that they understand exactly what the measure specifications are. And again, what are the items that make them fall in the denominator and then the numerator, so that they're clear on what it is that they're being asked to do. And then ensure that the medications are properly documented and follow up with patients who need prescriptions for the recommended therapy. Again, this can be a phone call. This can be done over, you can call the patient and have a telehealth visit with them, explain the need, and write your prescription. So that is something that you should be looking at now, even ending the year for your current patients, and periodically throughout the year as you proceed with the year. Just a quick note on HIV linkage to care. Sometimes we see a large denominator, and that always kind of raises a question mark in my head. If you have a very large denominator for the HIV linkage to care, you do want to really review those patients in the denominator and make sure that they're all truly first time ever diagnosed with diabetes, with HIV. That is who you're supposed to be targeting, patients that were diagnosed for the first time ever at your center. And so we want to make sure that you're looking at the right set of patients. Some EHRs, I know, if you don't actually put in a date of when you add this to the problem list, will default to the encounter date. And so that's where sometimes we get a problem. If the patient was diagnosed years ago, but they're just coming to your center for the first time and you're entering it, you do want to put the correct date of their first diagnosis. and don't let it default to today's date. So just make sure that you're checking that. Usually your staff that are doing your HIV counseling will know when patients have come in for the first time or been diagnosed for the first time at that center. So always check against your manual logs. So these are just a few hints. And again, I'm hoping for a much, much better year in terms of our quality measures in 2021. And thank you for your time and attention.
Harut, we did have one question. It was in reference to the center data for depression remission. Do you know anything
Yes.
about the availability of when that will be available?
So for those centers that are on Intergy with us, they are going to be releasing that report sometime this month. We do take time to review those before we roll them out for those that are under our data. And so we will be getting those reports in sometime in January. I don't have an exact date, but it will be sometime in January.
Okay, thank you. And I would guess that's the same for PAP? The
That
PAP
would be the same
quality?
for mammogram. The mammogram report, the new mammogram report, and the HIV screening report are all new UDS measures that we'll get when we get the updated PA reports.
Okay. And then the only other question I had for you was about dashboards. Do you have any updates on dashboards being updated?
That is what I just answered. The dashboards
Okay.
for UDS will be updated. You'll have the updated PA dashboard reports for UDS in January.
Okay, that was it. I got a few of those in the chat. Thank you, Harut.
All right, thank you.
I know we are short on time. If you guys can just hang with us for a few more minutes, I do want to hand it over to Diana Chavez, our Diabetes Program Coordinator. Are you with us, Diana?
Yes. Thank you so much.
All right.
So today's discussion with Dr. Torres was amazing and a very good leadway to my section, which I'm going to try to speed up because Harut covered a lot of it as well. But first, I wanted to thank everybody that you see on the screen. All of these health centers took their time out of their busy schedules to nominate a nurse during the November Diabetes Awareness Month last month. So thank you so much. You didn't only just submit the application, but you actually replied to my email with a picture of these amazing healthcare heroes. And we were able to promote them in our Instagram and LinkedIn accounts. So thank you so much. It was very heartwarming to read all of the initiatives that they take part of at your health center. So also part of the Diabetes Awareness Month, we sent out communications on preventing diabetes, so screening for prediabetes and the diabetes prevention programs offered by the CDC and AMA. So I just wanted to point out here, we're currently reviewing the ADA guidelines for 2020, and part of that talks about screening for prediabetes, specifically the sections that you see on your screen. So section 2.6 talks about risk tools, 2.7 talks about asymptomatic patients that you should be testing or screening. And then section 2.9 talks about testing everybody over the age of 45. And finally, section 2.8 talks about the risk of pregnancy and getting diabetes, especially when you are overweight, obese, or have one or more other risk factors for diabetes. And if you go to the next slide. So in trying to promote these efforts by the AMA, they also promote these websites that you see on your screen, which I have linked and you will have access to. These are pre-diabetes risk tests that you can take online and that you can promote at your health center for your patients to take. This was one of the questions that I was asking Dr. Torres because it is extremely important. There are too many undiagnosed patients with diabetes. So I know that we focus a lot on the UDS measure and taking care of our diabetic population, but we also need to address those that haven't been diagnosed yet or that are at risk of becoming diabetic as well. Next slide, please. This was a poll question, but we're going to skip it because we are tight on time. So you can go to the next slide. Implementing a diabetes prevention program at your health center is very important as well. And the ADA actually also recommends that you do so. The CDC's National Diabetes Prevention Program is a national effort created in partnership with public and private organizations to offer evidence-based, cost-effective interventions to help prevent type 2 diabetes in your community. So one key feature of the National Diabetes Prevention Program is the CDC's recognized Lifestyle Change Program, which is a research-based program focusing on healthy eating and physical activity, which has shown to reduce the risk of developing type 2 diabetes by 58% in your patient population. So if you are interested in participating in the Diabetes Prevention Recognition Program by the CDC, we encourage you to download the Organizational Capacity Assessment tool, which we have uploaded to the GoToWebinar, and you can download directly, or you can access that website link that I linked on the screen. Next slide, please. On that same note, and the last resource that I want to share with you today is the AMA and CDC's Diabetes Prevention Toolkit, which was developed to help prevent type 2 diabetes as well. Healthcare teams can use it as a guide to screen, test, and act today to refer these patients to that diabetes prevention program that we just discussed, or others that may be available in your community. The link to that tool is also available for you to download either through GoTo or on that link that I posted on the slide. And of course, if you guys have any questions, please feel free to email me. As your diabetes program coordinator, I'm here to help. Thank you.
Thank you, Diana. Appreciate it, and thank you for being fast. I know we're tight on time. I also want to just do some quick plugs for us, so I will be quick. In terms of Class Art Collaborative, I just want to say a huge thank you to all of you. This initiative was a huge success, and we couldn't have done it without you all. Across the 7 participating health center controlled networks, we had a total of 3,566 individual responses to the survey. 123 of the 145 health centers eligible to participate participated, which is about 85% participation. HCN, Health Choice Network, with our member centers, provided a total of 703 completed surveys to this. My plug, this coming Thursday, December 10 at 4 p.m., we have sent to your C-suite, to your CEOs, your COOs, we've sent it to your medical directors as well. Class will be unveiling the all-network aggregate data review and responses. As a network, we're coming together to see what we can do with this next. This is going to be the start of a journey. It's going to take a few years to go through this, but we are going to make some decisions based off of the survey results. We're going to be sharing these with the individual health centers as well. Responses, of course, were anonymous, but your health center will receive a report for your responses. So please register for this event, share it with anyone you believe is relevant that could attend this, but we did send it to your C-suite for attendance. So if you have any questions about this, please reach out to me or send me an email, and we'll make sure that we get the right people on that call. Our health center annual questionnaire for our grant, QTECH, which is what we meet about every month. Thank you. 11 of you have responded to my questionnaire. I know it takes some time. It's the one time a year we kind of do a pulse check with you all. 11 of 30 have done it. So please, you all know who you are. I'm giving a shout out and thank you to those of you who have taken the time to fill it out. We did send it in an e-blast. It takes some time to fill out. When you click on the link, we actually send you also a PDF version. So you might want to download the PDF version first and then meet with your folks in quality and around your health center who you may need to help fill it out, because we do have questions on cybersecurity. We've got questions on promoting interoperability. We've got questions on quality measures, on patient portal usage, on provider burden. So it may incorporate several team members to answer the survey, but we really would appreciate if everyone can get it filled out. I will be sending it out again after this meeting, so be on the lookout for that. World AIDS Day was on December 1st. We did have already 2 webinars, one with Care Resource, which was fantastic, and then we did part 1 of our high-tech webinar series yesterday with Dr. Long. Our second one is coming on December 7th at 11:30. If you're interested in registering, this one is Greenway specific, so it is for Greenway Intrag users. But if you're interested in this, we will be demonstrating, highlighting things on forms, flow sheets, health reminders that are most useful for the health centers for HIV patient care. Our SysOp team will be presenting along with Dr. Long, so please attend and share. And then finally, we do have our Alliance Chicago and Health Choice Network have partnered together to bring together a speaker from BKD to talk about anticipated changes in telehealth for documentation for 2021. They're going to actually look at clinic note examples with permissible documentation. Oh, my slide keeps jumping. I apologize. And reflecting on changes for telehealth visits. That is happening on December 4th at 2 p.m. So if you're interested, please register for that. And I know that I am over on time, so thank you for hanging in there with us. I know there's still 40 of you out there. Next meeting is January 28th, 2021. That is a typo. 2020 is ending, so we will see you on January 28th on 2021. Same time, I will be pushing out a new calendar series because our series did end at the end of this year, so I will be pushing that out to everyone. Happy holidays, stay safe, and thank you. Bye, everyone.